Awesome. Appreciate you all being here. Part of what I want to accomplish today is to kind of give some direction, all right? I know that when your loved one or when you are diagnosed with dementia, there tends to be a lot of question about what's next, or even sometimes trying to even figure out if getting a diagnosis is what's needed. I feel like there's sometimes just a lot of uncertainty when things start to change. So I wanted to get into some of the details of what does that look like and how can we help you and what resources are available for you out in the community. So we'll talk a little bit about some of that stuff from the medical perspective. As was mentioned, I run a clinic called Neural Effects, and what we do is we do diagnostic testing with neuropsychology to identify cognitive status of an individual. And then we have a whole bunch of other treatments and therapies and other things like that that we'll get into as well. My background is in the neurosciences as a nurse practitioner. When I got my doctorate degree, I immediately started working in neurosurgery and was working in the operating room every week, taking out tumors and bleeds and learning the structure of the brain pretty well. And then I got to a point where I wanted to work on the function a little bit more. So we got into the functional side of neurosciences, and we treat traumatic brain injuries and concussion, and that's what we started out with, and now we're working more towards the acquired brain injuries and dementia and things of that nature. So I want to just get into all of that with you guys and help maybe make some sense of things that, I don't know, maybe you've heard bits and pieces and you wonder, what does that have to do with me? Well, let's put it all together, all right? Some of the goals of my presentation today are to define dementia a little bit and how it's diagnosed, to get into some of those, of course, details, as I've mentioned, about where do we go with that once we have that information. All right, so I think starting off with this question is valuable because we hear the term. I think we all know somebody or have met somebody or care for somebody who has that diagnosis, but what does it really mean? And one of the questions that I probably get more than any other question when people come into my office is, what's the difference between dementia and Alzheimer's? Everybody wants to know what is the difference and what is it, and because those two terms are used so interchangeably, but the fact is they're kind of the same thing, and I'll explain that here in just a second. But dementia, of course, is a change in cognition, right? It's a decline in the mind, and I'll tell you exactly how we diagnose that here in 1 second. But first, I want to teach you a little bit about what the difference between the dementia and Alzheimer's is. All right? And the best way to describe this is to describe it as kind of the dementia umbrella, okay? When I talk about dementia, first thing I try and help understand is dementia is the umbrella, all right? And underneath that umbrella, there are multiple types of dementia. The most prevalent type is Alzheimer's disease. You can see 60 to 80% of all cases of dementia are going to be Alzheimer's. And that is why everybody uses those terms interchangeably, because chances are pretty likely if you've got dementia that you're probably going to have the Alzheimer's type. So when people come in and say, what's the difference between dementia and Alzheimer's? Well, Alzheimer's is a type of dementia, okay? And then you'll see here there are multiple other types. Vascular disease, so people who have had a stroke or who have had maybe high blood pressure that's been unmanaged for decades, those people are potentially at risk for developing dementia as well. And so that's a vascular type of dementia. And we can diagnose that based off of, sometimes you can find on the MRI changes in the white matter of the brain, or you can find the patient's history as a good indicator of unmanaged hypertension or a stroke or something, and you can diagnose that vascular piece. And so a lot of times, as you can see there, 50% of patients with Alzheimer's also have a mixed type. So there might be some of those patients who did have a a stroke or have had some vascular components. Or you can see these other types of dementia as well that are underneath the umbrella. We've got Lewy body dementia. For those patients, you're going to see a lot of times initially a change physically before you start to see the cognitive piece, where you're going to see it looks a lot like Parkinson's disease with some of the stooped posture and shuffling gait and things of that nature. Frontotemporal dementia, we're going to see patients develop that presenting initially with, come on in guys, presenting with some behavioral changes. Parkinson's disease, that's a whole nother avenue, but Parkinson's disease is something that people often develop, and then they develop dementia with Parkinson's disease. Anyway, you can see there are a whole bunch of other smaller subsets here that are part of that, but when we talk about Alzheimer's versus dementia, you can just remember that Alzheimer's is a type of dementia, all right? Okay, so when you get an official diagnosis of dementia, that doesn't mean we've identified the type yet. Sometimes we want to then go and get an MRI of the brain and see if we can see vascular components, or if we can see that the frontotemporal lobes of the brain are atrophying or shrinking or anything like that. So there's a little bit to it to figure out specifics, all right? But that leads me to, how do we get the diagnosis, all right? So the diagnosis comes, and there are certain criteria that have to be met. And there are three parts to this, essentially. The first is, to diagnose dementia, you have to have a memory component. So there has to be some change in the memory. And that's oftentimes the first thing that people really notice is, my loved one or in myself, I've noticed a change with memory. I've seen repeating questions, or we talk about something and a few minutes later we talk about it again, right? So that's sometimes the first stuff that people notice. So memory is definitely a part of it. And what I typically say is it's memory plus one, meaning when we do testing, we check to see if the memory is in deficit, and then in order to diagnose dementia, because sometimes just memory changes are age-related things. It doesn't necessarily mean somebody has a cognitive deficit. But memory plus one other domain of the brain. So memory plus some verbal deficit, memory plus executive function deficit, or any of these things, attention, processing speeds, all of these different pieces here, there has to be memory plus one of those in order to officially diagnose dementia. Now, we also take a third party's perspective, because dementia is not just a single person thing. Right? You're all here as caregivers or individuals living with dementia. And that is something that usually it's multifaceted. There are a lot of people involved, okay? And so with that, we are also looking for a report of some sort of social or occupational change, meaning I have noticed that there's a little more reclusiveness with an individual. They're not as outgoing or engaged with others, or want to be quiet or, be reserved. So these pieces are kind of some of the things that we're looking for to be able to officially diagnose. And when we are looking at the diagnosis, neuropsychology is the gold standard for diagnosing dementia. Now, you can get a diagnosis from your primary care doctor or at an internist or a neurologist, and they may run a simple test that takes 5-10 minutes, and you can officially diagnose that way. But to really identify specifics of what's going on within the brain, a neuropsychological evaluation is kind of the gold standard. When a neuropsychologist has made and identified a diagnosis of dementia, that tends to open up some doors for some other potential treatments and other things in healthcare. So having a neuropsychologist identify it is sometimes the most beneficial way. It gives you a little more information. And it also gives you specifics about, okay, what parts of the brain are working well, what parts maybe we see a little bit of that decline in, what areas need to focus for treatments and therapies. And so having a neuropsychological diagnosis is very helpful. At Neural Effects, where I work, we do these full neuropsychological evaluations. They take about 2 to 3 hours to accomplish. There's a clinical interview piece where we sit down and talk about what's been going on, and then we do those specific assessments where we look at the details of cognition. With these tests, what we're doing is we're gathering all this information, and then we are comparing this individual's scores to that of people in their same age with their same education level to see if they fall in that same average area, above average or below average, in areas related to memory or executive function or attention or all these different domains of the brain. Okay? Or we can compare you to yourself if you've previously tested, which is obviously going to be the best way to be able to identify what an individual's cognitive ability is. So for that reason, I encourage people to get a baseline. Even if you don't feel like there's necessarily a cognitive deficit, a baseline is a great thing to establish so that if you down the road are starting to notice a change, we can say, oh, in 2024 you were performing at this level, and at 2026 we notice this change or something like that. And that helps us kind of direct some things as far as what might be beneficial in treatments. Okay? All right. So you go through this whole process of identifying what somebody's cognitive status is, right? And we can identify, is this dementia? Is this related to age change? Is this a mild cognitive impairment that is as a result of maybe a brain injury from the past? Or, these tests help us identify where are we on that, what the brain is doing. And then we need to know, what are we going to do with that information? Just having the information is not always helpful, because I can bring in and test you all day long and say, here's what's going on. And then if I just send you out the door and you're left to wonder, okay, well, thanks for the info, but what am I supposed to do with this? It doesn't feel very good. It feels a little bit hopeless, all right? And so I feel very strongly about, once we have identified what's going on, we need to do something about it. And we need to identify what needs to be done, and we need to get everyone who's a part of this individual's team involved. We need to get caregiver support, we need to get family on board, right? We need to start working on making this the best thing that can be for that individual. So when we talk about what's next, we oftentimes start with, okay, what can you do for yourself? All right? And there are some pieces to this that we talk about every time we sit down after we've done a test with somebody, and we get into the details of, what does lifestyle have to do with this? You've probably all heard, right? If you're eating healthy, if you're sleeping well, if you're staying physically active, right? And if you're doing puzzles and all sorts of stuff, that's going to be one of the best things for you. And that is accurate. But sometimes that feels a little bit lonely if you're just doing that all on your own and trying to figure out all that stuff on your own. But I do feel very strongly about making sure that people are aware of these pieces. Diet is huge. Individuals who have been diagnosed with dementia, we really strongly push Mediterranean diets. There's a doctor out of UCLA, his name's Dr. Dale Bredesen, and he's written several books about, he calls it the end of Alzheimer's, where he feels like if people really focus on certain things that they eat, they can reverse the process. Now, I feel like he's a little bit on the extreme end of things. I don't quite see that happen for people. But I do feel like by what we take into our body, we can maintain things a lot better. I feel like we can prevent further decline if we're giving our body the right things, right? Our brain is made up of 60% fat. And so if we're bringing the right kinds of fats into the body by eating less processed vegetable oils like we eat a lot of here in the United States, and maybe more, avocado or olive or coconut or fish, those kind of fats that are good for the brain, we're going to be giving our brain the best things that it can have to be as healthy as it can be. So we push Mediterranean a lot because also in the Mediterranean parts of the world, there are very few cases of dementia. And they attribute that to the fact that these people have lived a very specific way for so many centuries, where they're physically active because they don't drive everywhere that they go, and they are very specific about what they eat, whole foods and vegetables and stuff right out of the sea, right? All that kind of stuff is good for the brain. So we push that and we talk about that. So keep the lifestyle pieces as an important factor. Physical activity. We know if we're walking and running and doing things that are going to get the blood pumping, we're going to be providing the brain with the nutrients that it needs, right? Our blood contains the neurotransmitters and the oxygen and the glucose and all those things that the cells of the brain need to function properly. So good blood supply is going to be important, and staying physically active. Good sleep is huge. I can get into a lot of detail here. I don't know how much I want to bore you with this, but it's interesting to me. But there's a system in our brains called the glymphatic system. And this system is something that really was only just recently discovered. As early or recently as 2017 is when we really started to know about this glymphatic system. You know, there's a system in our bodies called the lymphatic system, and it pulls kind of the bad stuff out and excretes it out of the body. The glymphatic system does the same thing for the nervous system in the brain, and it pulls out all those extra neurotransmitters and things that the brain was using all day and cleans it out, but it only does it when you're in your deepest cycles of sleep. So for people who are not getting routine sleep, their glymphatic system is never kicking in, and they're just kind of gumming up the works, and it's going to make it a little bit harder to process in the brain if we're not engaging that glymphatic system as well as we could. So sleep's huge. And I say this last one, cognitive engagement, because I want to talk a lot about this. And I better check my time because I can talk a lot, sorry. But this cognitive engagement piece is huge. We know with the brain that the brain is a don't use it, lose it tool. And with dementia, that's even more progressive, okay? And we want to engage the brain as much as we can. The more that you're utilizing different neural pathways, the more likely you are to preserve them. Now, if you choose to not engage neural pathways, the brain is naturally going to kind of prune them away, or you kind of lose them. And so we hear, when we talk about cognitive engagement, we hear a lot of people talk about, all right, I should be doing crossword puzzles or Sudoku or other things of that nature. And those are great, but we've learned a lot about people who do those things become really good at those things. And we want to be good at all the things that the brain can do. So we need to find a way to engage the brain across the board, not just with some games or puzzles or things. Though I'm not discouraging that. I think that's great. Do those things. But let's broaden that just a little bit more, okay? And so I want to talk a little bit about how do we engage that brain more? What kind of neurocognitive engagement can we do? Now, I put on here this little bit over here about, once you have the diagnosis, the doctor who sent you to come get the diagnosis is probably going to follow up with you. They may add some medications or things like that. And right now in the market, medications for dementia aren't there to necessarily treat the disease. They're there to maybe enhance some aspects of deficit. So you'll probably get a medication like a memantine or a donepezil, Aricept. These are medications people have heard of probably or are on. And those medications are potentially helpful in enhancing memory a bit. They're not treating the disease, they're not getting it to go away, but they might enhance the memory just a little bit. And if that gives you, 3 to 5% a little bit better memory than you had, then it's worth it as long as the side effects aren't great. If the side effects are great, then I would say probably not worth it, right, to get that maybe 3%, 5% improvement. But I also am a big fan of any little bit of gain that you can gain with dementia is worth putting something toward, put something towards that gain, okay? All right. Oh, it went too far. Okay.
Tell us the doctor's name again from UCLA.
Oh, you bet. His name is Dale Bredesen.
Thank you.
and I think it's Bredessen or something spelled like that. I might have made that up just now. But yeah, he's got a lot of good information. I would read his books. I wouldn't put all of my eggs in that basket, but I would definitely take pieces of what he's researched and studied.
And the name of his book is?
The End of Alzheimer's.
Thank you, sir.
You're welcome. All right. So, cognitive stimulation therapy. All right, I'll go back to this last slide. The very last thing, that cognitive engagement that we were just talking about. I want to get into more of what is the best thing you can do to engage the brain. We talk a lot about socialization. During COVID, when everybody was trying to protect themselves from spreading disease and things like that, there was a lot of isolation going on. And we actually saw a large decline in cognition in some of our geriatric patients. And that is because they weren't getting that social connection. They weren't out there connecting with other people. We know that when you're social, your brain is activating multiple neural pathways. Your brain, when you're talking to somebody, is thinking about what they're saying. You're visually interpreting body language. You're processing old memories and thoughts and feelings. You're hearing opinions and you're forming new opinions, right? All of these different areas of the brain are being activated when you're conversing and being social. And so we know socialization does more for the brain than just about anything, which is why I say, puzzles are good, but you're going to get good at those things, whereas socialization, you're going to get a whole slew of things that are going to help. So we at Neural Effects, we have a program called Cognitive Stimulation Therapy. It's part of our Empower program, where what we do is we bring people together who have recently been diagnosed with dementia, and we get groups of 6 to 8 people, and we do therapies twice a week for 1 hour each. And those therapies are doing multiple things. We always start off with physical activity because we want to try and get the heart rate going and get the blood pump into the brain. And then we immediately move into orientation therapies. We have a group name and a group song that we sing together because music is great for the brain. And sometimes it feels a little bit juvenile when we're singing, but I promise it always is good. It leads to really good things. We establish that group name and group song so that there is consistency, because consistency is huge for the brain when it comes to dementia. And repetition and those kind of things can be very beneficial. So we identify those things. We do orientation to time, place, person, situation, weather, all that kind of stuff. And then we do reminiscence therapies, where we work on talking about things from our past and reminiscing together about things that mean something to us. We have current events where we talk about what's going on in the world around us so that we can form opinions and hear other people's opinions and activate those areas of the brain that you might not otherwise be activating when you're watching television or something, for example. We are working on other activities in the groups that we do that help with things like executive function and being able to execute tasks, or things that are working on attention or memory. Every time we get together, there's a set program that we follow. The program was developed in the United Kingdom about 25 years ago, and it was developed by Dr. Amy Spector. And it has been researched like crazy for so many years. And because, the United Kingdom is on socialized medicine, they send everyone through the program, so they got a lot of data because they put everyone through the program about what it does. And the research right now shows that it is as effective as any medication on the market in preserving cognitive function and reducing that decline. And so we work hard on getting that stimulation in those group settings to help people preserve that function. But not only that, it's a quality of life thing. It also puts something on the schedule so that you're routinely getting out and you've got something to look forward to. I feel like people do really well with it. I've got a few folks here that I see that are part of this, and I love to see you here, and it makes me happy, but I know that it's very effective and it does a lot of good things for life. Because not only at the time that we're doing these group sessions, we're helping those individuals, we're also working with the caregiver and the family. We've got a couple of rooms going on. The caregiver and family are also doing a little support and getting resources and connections and other things that can be very beneficial so that they know what direction to go moving forward and what to expect. And when things come up, there are resources within their grasp where they can grab a provider and say, hey, I noticed this change in my loved one. What can we do about that? So I feel very strongly about what benefits cognitive stimulation therapy can provide. And it has been awesome. It's my favorite part of my job. It's fun, and we have a good time, and everybody sits around, and we talk, and we laugh, and we connect, and we form bonds and relationships. And I've got a couple of my staff here in the back, Liz and Skylar, who are very helpful with this. Skylar's our registered nurse, and he runs the cognitive stimulation groups. Liz is another nurse practitioner at our clinic and helps get some of the testing done and set people up for some of this stuff. So anyway, we're very happy about this program, but I want people to know about it. I want people to know that there is something out there that you can actively be working on. It doesn't just have to be you get a diagnosis and then you go and wait out your days or just wait for decline to happen or something. Do something. Actively engage, right? The brain needs that. Okay? Which leads me to a little bit more of what does the future hold? We've got a lot of stuff being done in the world right now in the research of dementia. There is, of course, the drug companies are looking for medications that could be helpful. And you hear about a new one that comes out every once in a while. And right now there are a couple on the market. There was one that was pulled off the market a few months ago called Aduhelm that they ended up finding had worse side effects than the actual benefit that the medication had. And it was kind of expedited through the FDA process a little too quickly. And then they found out later that it wasn't as helpful as they'd hoped. So there are things like that happen. Right now there's another medication on the market that it looks like it might be on the same track. But the good news is people are putting the effort in. They're putting the resources in to try and figure this out. And I think there will be some stuff that's up and coming. There are a lot of good things with blood tests and other stuff that are also coming on the diagnostic side, but I think there are a lot of things in the future that will really help us. But right now, some of the greatest stuff is this cognitive stimulation therapy. And then we have some other avenues that are being explored currently. And this is something that we're actually working on at Neural Effects. And I don't want to get too deep into this quite yet because we literally are just working through the details of how this can affect people. And with this, we are using what's called transcranial magnetic stimulation, or TMS. And TMS may be something that some of you have heard of. It's usually used to treat depression most commonly, anxiety or OCDs or other things like that. And what it is we put an electrical magnet coil on somebody's head and we send signals through electrical pulses into the brain. And we use functional MRI guidance to identify specific areas in people's brains that maybe aren't firing quite like they should, which can lead to things like dementia. And we activate those areas. And we activate them by deionizing neurons so that polarization, anyway, there's all sorts of scientific garbage I can get into, but what it does is it allows those neurons that maybe haven't been firing to start firing again and regain maybe some things that have been lost for an individual. And this is very kind of cutting edge stuff. There have been studies done on this in some Asian countries. There's several studies out of China, out of South Korea, other places that are very promising. But here in the United States, we haven't really grabbed hold of this quite yet. But at Neural Effects, we've got the machine, we've got the equipment, we've got the functional MRI, we've got everything that we need to do it, and we've started running some patients through it, just, preliminary, just studying it, seeing how it's going. And so far, it's going incredibly well. We try to do about 3 weeks worth of treatment. They come in for an hour a day and spend 20 to 30 minutes on the machine, getting certain bursts and pulses in certain patterns that can be very beneficial to activating those pathways in the brain. There's very little risk with this because it's just magnet. It's not going to cause a major shift or change physiologically in the body or something like that. Yes, if there's metal in your head, don't do this. Yes, that's exactly right. But there are a lot of really incredible things that are coming. One of the things that I heard from one of our patient's family members this last week was we were all together on Sunday as a family, and Dad's had his diagnosis for several years, and we've seen the decline. But on Sunday, two of my siblings that aren't around as often said, it feels like Dad doesn't even have dementia. He just feels like an older gentleman who's maybe occasionally forgetful. But what it's done is it's reactivated that engagement, that affect, which sometimes we lose with dementia, is the affect, that ability to feel engaged. And this is reactivating some of that, which I'm really excited about. I know it's still too early for me to get into all the details or to say, I'm offering this up to everyone, right? I hope that very soon we'll be able to do that. But I do feel like it won't be long, and there will be some things that could really benefit people with this. All right? Yes, please.
Is that treatment recognized by Medicare and therefore has some coverage?
Not yet. It's recognized by Medicare for other purposes, for depression, anxiety, and so it's covered for those. So we know that it's a safe treatment. It's been around since the 80s and 90s, and it's been being used for those purposes regularly. As of right now, we're going to probably be the ones that go through the process of getting an FDA approval on this and getting it so that people can actually use this treatment for this purpose. Right now, we're using it off-label is essentially what it is. All right. But I just want you to know there are things being worked on. There is hope for the future. There is change and good stuff that I think can really be beneficial. And right here in Utah County, we're going to be some of the cutting edge on some of this stuff, I think. And so we'll work on that and let you know.
So I'm learning that magnetic stimulation actually comes from sound.
Okay.
And so my question to you is, would it be beneficial for us to have more speaking engagements with those that we care for so that sound can act as a magnetic stimulation for them?
Okay, and you're opening a whole can of worms because I got a lot of thoughts about this. Oh, yes, sorry. The question was, I understand that you had done some research and that magnetic stimulation and sound have a lot that go in common, and is conversing with other people going to be beneficial in potentially giving some of the same benefits that this TMS could give. And we actually have a lot of research going on right now, and we're not doing it personally, but here in the United States with ultrasound and what it can do for getting stimulation of neural pathways in the brain. And so there are a lot of things that keeping engaged with people are going to definitely improve outcomes. Talking and conversing, huge. No question there. Will it give you the same quiet benefits as this? Maybe not, because it's a little more concentrated and it's pretty intense, the amount of delivery that we're giving with this. But I 100% will say yes. Stay engaged. Talk regularly. Keep those neural pathways active that way. Okay? All right. But we're going to keep working on some of this stuff, and hopefully we'll have some really neat things up and coming. And I hope very soon we'll have some really neat things that can be offered that can help as well. All right? But yes, question back here?
Last year, when I visited your clinic,
yes.
you mentioned that you were moving. And now, are you still in the same place, or have you actually finished that move?
So we're in the Riverwoods area by Provo now. We used to be in the Physicians Plaza right by the hospital, so we have moved. That's what the question was have we moved? And so yes, we moved in January to the new location.
Oh, last January?
So yeah, just this past January.
So when we
This year.
make the follow-up appointment, we'll go to the Riverwoods.
Correct. Yes. Anybody who's going to come see us in the future, come to the Riverwoods. All right? Okay. So I feel like there's a lot of good up and coming, a lot of things that could really benefit people. I feel like there's a lot of good to be done right now. Start with the cognitive stimulation therapy. Engage. Get caregiver support. Come and learn what we have to offer. I'd be grateful to have you. I just want you to know there are resources, and we'll put those resources, we give that to you. We want to connect you with people. We bring MAG in once or twice a month where they present and teach us a little bit about their stress-busting classes and their caregiver support groups and everything that they have to offer. And we bring some other home health groups in to line you up with what you need that can help you in your situation. So overall, I want to make sure that everybody just knows what's available for you right now. Utilize the resources you have. Yes, and the question is, are there other clinics like us that are accessible to patients as we continue to grow? We are, right now, the only group that I know of that does cognitive stimulation therapy in the state of Utah. And like I say, it's all that evidence-based. It was brought over to the United States, the University of St. Louis, and we piggybacked on them and built from them. There are places like the University of Utah are doing research on dementia. However, I don't know what their research is, and they're not giving me a lot of detail there. I don't know of any other places that really offer a full treatment process, from diagnostics to the care, and quite like what we have to offer.
Does insurance address the cognitive stimulation therapy insurance or Medicare?
It does. So we have been running it through insurance all up until about right now. We actually just made a change recently because we've, for the last couple of years as we've been running this program, have realized that most insurances treat it like it's a physical therapy visit, essentially. And they charge you a copay or something along those lines every time you come in. If you're coming twice a week and your copay is $30 per visit, it adds up pretty quickly, and then insurance covers the remainder. So we actually recently just changed the way that we're doing this, and what we're doing is we're going to charge everybody a flat rate of $20 per visit. And so it's cheaper than most people's copay. And then we're not putting it through insurance because it's more affordable for you to just pay out of pocket than to pay the $30 copay and put it through insurance. So we're trying to keep this at a price point that everybody could access it. And so we feel like at $20 per visit. And then once you hit 7 weeks, we go down to once a week and we do more maintenance than we do. The first 7 weeks is twice a week while we're trying to establish what the brain needs, and then we go to once a week so it's more convenient as caregivers and other things like that. Okay, you're welcome. And so the question is, are there resources that are provided to help people, maybe even get to these classes and other things? And we do have resources through connections, like things with MAG, or there's paratransit here in the county, and we've got some patients who are using paratransit. And so those kind of things are fantastic. We don't personally have a bus or something that goes and picks people up. I'd love that. A valet service. I love the idea. We're thinking big, and I like that. All right, but we're not quite there yet. All right. Okay, well, I'm running up here on the last 5 minutes, it looks like. I wanted to just touch on a couple of things, just some personal experience, just so that you are, that you understand that what I want to do is bring this from a place of, this means something to me. I don't just do this because I went to school and I'm trying to find my avenue. I do this because it's very personal to me. I've got some pictures up here, and I guess you all imagine I'm going to be talking about personal things. But anyway, this is a picture of my father, and this is my father-in-law. And about 2 years ago, my wife and I were just coming home from church, and we got a phone call that her dad wasn't doing so well. And so we, being in the medical field, I get a lot of requests from family. Will you come check on this, or can you get me an antibiotic, or that kind of stuff. And I'm happy to do that, but come and check on Dad and see if we can help in any way. So we rushed out to the farm and where he lives, and the ambulance was on its way by that point, and we met them there. And anyway, carried him out and headed off to the hospital. And partway on our way to the hospital, the ambulance pulled over, which is never a good sign. And my buddy, who's the police officer on this case, on this transport, came over and said, doesn't look good, probably not going to make it. And so he'd had a cardiac arrest, and we lost him on that day. And we ran home and told all the kids, and the kids were devastated, and we were there comforting our children. We got 6 kids. My wife's here in the audience, just so you know. But anyway, we got 6 kids, and we were devastated. And while this was all happening, my phone was going bonkers, and I just kept ignoring it because what could be more important than what I was doing at that moment in time? And when we told our kids and talked about it, I finally pulled my phone out and noticed I had 14 missed phone calls and 20-something text messages, and I started looking through it all, and everybody in my family was trying to get a hold of me to let me know that we needed to get over to another facility because my dad was on his way out. That was unexpected. We knew that my dad was declining. He had Parkinson's disease. He'd had it diagnosed for 10 years previous to the time that he died. But we didn't know he was going to go that quickly. He was actually just in a care facility for the weekend because he and my mother were going to move into my house so that we could be further caretakers for them, for my dad, to take a little of the burden off of my mother because she was doing a lot on her own. And we got to that point, got everything set up, put my dad in that care facility so that my siblings and I could all gather up mom's stuff and move her in. And apparently, as soon as my dad knew that mom was taken care of, he decided it was probably time to go. So within about 6 hours of my father-in-law passing away, my dad passed away. And we had been caregivers for my dad for 10 years and had watched him decline over that time. And it was starting to affect him. And he couldn't speak anymore. Cognitively, there were some changes. There was a lot going on with my dad. And I was, being the medical provider in my family, I didn't have any others involved there. I was stopping by on a regular basis to see if Dad's needs were being met and change his, diabetes measuring tools. And I would carry him to the bathroom or carry him to the shower and help take care of his needs that way so that it wasn't all on mom. Home health was in there as well, and that was helpful. But I was a caregiver with my siblings. Well, with half of my siblings. No, just kidding. There are 8 of us. 4 of us were a little more involved. But anyway, that's part of the caregiver process, right? You can't get everyone on board all the time. But anyway, I was a pretty heavily involved caregiver with my mother. And it was hard. We grieved the loss of my father for 10 years while that was happening. But it was also grief once he was gone. When my father-in-law passed away, it was unexpected. And it was fast and sudden. And I have had so many people ask me, which is harder, to watch somebody decline over that period of time or to lose somebody all at once? And there's no right answer. That's a terrible question. All right. But I want you to know that it gave me a little bit of perspective, a little bit of understanding of what my role as a caregiver really meant and what benefits I got out of having those years with my dad, even though he wasn't quite what he once was. I am grateful to have been a caregiver. As much as it takes its toll on all of us, it sometimes is a lot of work, but it takes a team. And I know that we gain a lot for that. And I love the people who are in need of the care. I love the people who are giving the care. I love it all. And this means a lot to me. We didn't know what resources we could have. We didn't know what was available to us. And that's where I have been building this Neural Effects Hub with my amazing team so that people have those resources. And I want you to know there are resources available. Don't just do this on your own. Find the resources and utilize those resources. It's so important. Anyway, I appreciate you all taking the time to come out and listen. I hope that something came of this, maybe a little bit of understanding or what to do and where to go from here. But my time is up. If there are any questions, I don't know if we've got time for questions We don't. It's time for lunch. Everybody's going to be satisfied with that. It's time for lunch. But if you find me, I'm at a booth over here if you have questions. All right. Thank you all so much.